nurse Tammy Cossett was the one registering you, and hopefully Max is an instructor, so I might be deputizing him to help if some of the other instructors don't show up today. I was hoping Dr. Chilton would be here this morning for a stop. He may or may not be here, so we're just going to move on. What the format pretty much is in the till about 10:30 we have American Heart videos. The first one is a review video that goes over all the 2010 changes. You know, we're going to have new changes coming out in 2015, the fall of 2015. Every 5 years, American Heart looks at their guidelines and revises. I have not heard anything. I haven't heard any rumors about what the changes are going to be. Once the new standards come out, we can't do a recertification class like today is. It has to all be the full class once the new standards come out. But that won't happen, like, as I said, until fall of 2015. So we'll do a review. We'll watch a respiratory video that goes over the capnography. There's a lot of questions on the test about capnography. Here at Audie Murphy, we have capnography in the ICUs, but our crisis cards don't have capnography capability at this time. Where once you intubate it, you just put a little sleeve over, and then you can see the readings. Apparently, as we replace defibrillators, we'll get the ones with that capability, but we don't have them. We don't have them now. Then at around 10:30, I think 11, the rep from the IO needle is going to come and go over that. We will check you off on your BLS skills, hopefully this morning or right after lunch. And look at the crisis card, check you off on your airway skills. And airway skills now just means you can put in an oral and nasal airway and use an AMBU bag. They're pretty, because to intubate you have to have special privileging, so we don't do that anymore. And then we get to eat food, and then you come back and start written tests and medical testing. That's pretty much the schedule. Any questions?
What do we have for lunch?
I don't know. Well, you have a potpourri of choices down on the first floor. All bad for you.
Just for a second.
Okay. But is it too late now? And I screwed it in. Yeah. Like that, make it go away.
That's good. It's just slow.
Oh, okay. Never heard of that.
How many of you have had ALS before? Anybody? Oh, how many work in intensive care units? One or two of you? Okay. Are most of you in primary care areas?
No, we're
4A? 4A? Oh, you're in insurance. That's okay. You say that. They're all going insurance. What about you guys, friend?
Surgery clinic.
Oh my gosh, it's been hard to me.
Well, hard touch.
Oh, we use your blood sometimes. That's all right. We've been using a lot of it lately. You know, okay. All right, let's see. Are you ready?
Well, it's
Just look. Okay. This section covers a lot of stuff. It's all in your book. If you try to take notes, you will stop halfway through. There's a lot of material, okay? But it's all in your book. We only test the material in the book, okay? But since we've had a slug of ACS, people having heart attacks in the last 24 hours, like 10 here in the hospital, including hospital employees, you might want to watch this because this may keep you out of the hospital. There's been a lot of young guys had some bad accidents in the last couple of days. So this part's really important. It will teach you how to EKGs and all kinds. But let me show you, this is an example of a 40-year-old, a 35 or 30-year-old lady, but I've got one just like this for a physician yesterday, and it looks just like that. And what, turn it on. What's happened is that this artery right here, that's a left ventricular artery is going down. If you look, it's got slow flow. That means the cardiocyte's downstream and not getting any blood. And if you look at the echo, the front of the heart does not move. But the patient, I feel pretty good right now, but I was having chest pain yesterday. That's acute coronary syndrome. When we did his troponins, they were up a little bit. So he's not an unstable angina patient. I'll go through the definition in just a minute. That's the kind of stuff we're going to talk about. Also, on this lady, look at the coronary arteries, how twisted they are. That tells you they got high blood pressure. How many people you have risk factors have only one? Rarely ever see that. If you have diabetes, you always usually end up having, on top of the high blood pressure, 80% of the time. So you don't get an isolated. And what that's telling you is your body is atherosclerotic. And so when you get something like this, it's look out, because everything else is coming downstream. Fortunately, most people have heart attacks first because the other option is you have a stroke first, and nobody likes strokes. In the first year after a heart attack, about a third of these people, not quite a third, will have a stroke. So you, in the first year after a heart attack, are very high for having a stroke. So you need to be, this is all cardiovascular. When we look at it, this is all ACS. You can fracture a little piece off your carotid, or you can fracture it off the arch, or you could just infarct it. All that stuff's about the same. But the ones that catch most of your attention is a stroke or heart attack. Let's see if I can get it before. This is not in your book. This is for your information. We build drugs only for certain places. Currently, if you look, we have aspirin for right here. We do not do things that affect this binding area of where the platelet comes down and sticks. It's probably too dangerous. You bleed too much. But this aspirin is a really big deal. And what's happened is aspirin has its major, like it can reduce the actual cardiovascular events in big heart attack trials to like 40%. So if there's one drug to take aspirin. If you're not sure, just take an extra one. You know, the only caution about aspirin is there's a new drug out there called Brilinta or ticagrelor. If people get stents put in, and you raise your aspirin dose more than about a low dose, 81 to 100, they can actually get more harm than good because it's too powerful. So that's the only exception, but I got to warn you about that because it just came on the market about 24 months ago, and it's coming around where you guys will see it in the clinic. Don't be raising aspirin to high dose, 325. Is there any advantage to raising aspirin to a higher dose? Do you think it could do a better job? One thing it does a better job on, it makes you bleed more. Okay? On the slide, if you look at it, you can see the thromboxane receptor. Thromboxane is what you get from meat. A few of you guys look like you eat steak. Okay? When you eat steak, it comes down and activates the thromboxane pathway. That vasoconstricts your arteries, and it also will activate platelets. So the thing I need to block, and the guy having a heart attack, I need to block the platelets. You guys work on those all the time. And at the same time, I want you to open your microcapillaries. That's why I use aspirin. It's really effective. The other thing it's just recently been found to do, although reported back in the 90s, we didn't pay attention to it, is that aspirin blocks a white blood cell from entering an inflamed area like a ruptured plaque. Well, you don't want more white cells to cause more damage to an inflamed area. So that's through cyclooxygenase 2. We didn't know that it blocked COX-2 until a few months ago. So now we know aspirin does COX-1 and COX-2. If a person has heart disease, always ask them to take aspirin in the morning first, not non-steroidals. If you take non-steroidals first, you block the binding pocket, and I can't get aspirin in there to have its effect. People get confused. Most people who take these drugs have arthritis. They will classically pick the non-steroidal first. So switch them around. Make sure they take their aspirin first in the morning, and then they can do it. You generate platelets back every 10 days, 12. So it's important that when you block it with this, that you don't give too much of it. 81 works as good as 325 as far as cardiovascular events, but you do increase significantly the bleeds when you go higher dose. Over here is two platelets, and in between it is fibrinogen. The things that allows platelets and fibrinogen to connect together is actually this specific receptor right here. The reason you need to know this is because later on in the talk, I'm going to talk about using drugs like these up here, and actually, these are the ones that we currently use in the hospital. The one that we use mostly is this epitepidide. This is the one that comes from the emergency room with coronary syndrome. We don't use too much the ReoPro or Tyrofide here. This one is an antibody, and it's very hard to reverse. If you turn this drug off, then it will be gone in roughly 4 to 6 hours, and you can operate. So that's the one we use. They are not cheap. These are over $1,000 around, and that's just one shot. And if you hang a drip, it's going to cost a lot of money. Now, you can get at the same thing and break these bonds if you give an oral agent. And the oral agents that we pick are the ones over here. These drugs affect the ADP receptor, and by doing so, ultimately, you affect this binding receptor here and turn this off. But that's 30% effective. That's 100% effective. So there's big differences in those compounds. Currently, probably nobody's beat clopidogrel entirely, although there are 2 trials just recently reported, Timmy 38 and Plato, both show that these newer drugs are more efficacious than this clopidogrel for cardiovascular endpoints. That has been changed in the guidelines, but currently we don't carry those at the VA, but we probably will over time. This only shows you kind of the whole problem that you have. The most powerful risk factor all of you have here is you didn't pick mom and dad right. Your mom and dad are more powerful than blood pressure, lipids, diabetes. So your genetics, if you want to know what's going on with the patient, you ask them, hey, you know, mom and dad have heart disease? Well, you know, dad died at 50. That's not good, because that guy is really high risk. That's because all the risk factors you guys normally talk about are we've been using for 30 or 40 years. We have not advanced in our academic status for knowing what's really important. So I think the best one still is the genetic codes that come down that you get given from your mom and dad. You may find that there's some that, you know, don't fit into early death, but boy, I tell you, they're really tough. Diabetes is really tight for genetics. So ask if they have a family history of heart disease. That does make a big difference to me, and I usually ask for that. This is the other one that most of you struggle with, especially right now. Because right now you're going to go eat all that fatty food. And when you do, you're increasing your environmental risk, because that has to do with your lipids and inflammatory circuits. If you don't take care of your teeth and you have poor dentition, you are going to have basically a higher C-reactive proteins that tells your body is inflamed, just like an infection. If you want to give a guy a heart attack, give him an infection and then load him with risk factors and then give him bad genetics. That usually will do it. He can smoke if you want. That's the kind of patient that we see in the cancer. Most of the time, that's it. Notice it's the blood or liquid tissue that carries all of your risk. If you want to get rid of heart disease, you're going to have to make sure that the blood going through you is clean and has no inflammatory signals. And if you infect it, or you raise your lipids, or you raise certain other risk factors, it's a problem. So blood is the next target. Now, what goes into the blood comes from the GI tract to a large extent. Now, you're thinking food, I'm thinking microbiome. The microbiome that you have in your gut actually controls a lot of these signals, and I would not be surprised in the next 5 years you will not see a shift to where the GI area is a target for atherosclerosis. You don't see it yet, but everything you eat goes into that and goes right into your blood, and if I'm tracking it from your blood, which we're doing now here on proteomics labs, we're finding that that is definitely affecting you. So when you lose weight, you have significant changes in your blood chemistry. Many, many cytokines go back to normal. If you gain weight, they also go the reverse direction. So you want to keep this as healthy as you can, including your, this is a healthy aorta. Age about 30. Take a look at this. Looks like pizza. That's what most of you, if you're healthy, you should see the bad ones. The worst. But this is an American aorta. It's probably 30 years old. That's kind of what we expect to see. Now, let's see the next slide. If I can get it to advance. Should I push it or wait? No.
There you go.
Oh, there it is. Okay, good. Now, here's another picture. This is the inside of the ruptured plaque. If it will play. No, it doesn't play. Oh, is it? Okay, let me wait just a second. You'll be able to see this thing play, I think. On intravascular ultrasound, this is the soft plaque in the middle that's got lipids inside. If you push your finger down on that, you will actually be like toothpaste and pop out. If you put pressure on the inside of the artery, like high blood pressure, you can crack the corner or crack the top of that cap. You can also see here on a new, this is optical coherence tomography, a very thin cap. That's what ruptures and what causes heart attacks in most people. Although lately we're finding some different kinds, but that gives you kind of an idea of the stuff that we face when we come to the cap out. Let me see if I can go to the next slide. Still loading that area. It just doesn't like these big movies. It just doesn't. Hey, let me see. Let me just go down to the right. Let me get this to play. Great, 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 great. This is, well, I showed you right. See this artery right there? This is all the remains of the inside of the artery. This is all atherosclerosis. And if I was to take and go down the middle of that artery and cut this out, this is the pieces I get out of your heart. And if you look at the pieces down the bottom, you can see that this kind of fatty looking yellow stuff, that's the atherosclerosis inside the artery. That's what we're dealing with. Now, if you say, you know, this is, you fix the artery, and you can see it looks real pretty here. Look down here at the bottom. It looks fine. Down in this area, this is the amount of atherosclerosis inside that artery. So you still have stuff in your arteries. All of you in this room have at least this much down here at the very bottom. There's nobody that doesn't have this stuff. How do we know that? Because we do transplants. And every time you have a 60-year-old guy that has a motorcycle wreck and you're looking at a transplant, we have to IVUS those kids. Those kids, because the heart costs $1 million, we look inside, they all have this. So all of you in the room have that stuff. The gals and the guys alike. You would think that you would not have it this big. So don't worry, there's plenty of disease around for everybody to share. The first thing is we're going to define acute coronary syndrome. This is an easy definition. This side of the room is acute coronary syndrome. This guy's acute coronary syndrome. And you guys are acute coronary syndrome. Here's how it breaks out. If you don't raise your troponins, but you got chest pain, but no ST elevation, that's unstable angina. That'd be the least dangerous. The guys in the back could have non-STEMIs, non-ST elevation MI. STs are not up, but you're leaking troponins. Now, that's also part of acute coronary syndrome. And all of you guys would have ST elevations that are high with positive troponins. So the two of you have positive troponin leaks. This group would be able to go home and potentially get worked up as an outpatient. You guys, since you leaked enzymes, carry mortality. So you have to stay until we get more information on it. We may release you if your enzymes come down and you feel fine and you pass your check-on. Otherwise, you would probably. So the algorithm's in your book, and you can kind of follow through that, but this is pretty much the way it goes. This is, again, showing the ST segments. I'm going to talk about that. I'm going to show you depression. I'm going to go through how to read an EKG. We're going to go through the infarction size definitions and stuff so you'll have it. Here's a classic case. I never get these. The classic case is a guy that's got sweating and jaw pain, as you can see here, and the 10/10 substernal chest pain. Many military guys won't tell you they got pain. They got somebody sitting on their chest. I don't know if they don't like to say pain, but they just don't complain about it. They'll get short of breath because what happens is when you're having a heart attack, your heart can't actually fill properly and actually empty properly. So it backs up into the lungs. When it does, it will pull on the lung bed and activate a thing called the J receptor. It goes up to your head, it makes you short of breath. So as soon as that short of breath clears, then they're probably doing fine. But most heart attacks, if they're certainly front wall, they will give you that impending doom, and you will find the heart rate goes up here, and you'll see their blood pressure and heart rate both go up. Those are telling you that their body is struggling. Now, if you get an older guy that's already had heart disease and his pressure's low, that means his heart's having such an infarct side or so much damage at one time that he may be in cardiogenic shock. So this is also a serious problem in the VA. Private hospital, not so much, because they usually just have one vessel and they don't have as much disease. You deal with the 6 patients I've got. And when they come in, you listen to them, because many of them, they all have heart diseases, whether or not it's going to knock them over. And that's the part that you have to work on to see if you can correct. This is the actual algorithm. You should do this within less than 10 minutes. It quite honestly can't be done very well. But you need IV access, you need to measure all these different things or send them off. I do need clotting function if we go to the cath lab for an intervention. If a guy has acute coronary syndrome, you can cool him off with different kinds of drugs as long as he's chest pain free. If he's not chest pain free, he needs to go get his artery open. If you look at all of our trials, the guys who win and have the least amount of damage is the ones who go to the interventional lab within probably less than an hour. You will determine 50% of your heart size in the first 20 minutes of a heart attack. You see it's 0 to 90 minutes, but in the first 20 minutes, that will account for 50% of the size of your heart when it's over. So your heart cells die really quick, so you want to get it into the lab and get them corrected as soon as possible. Here's all the things you need to know, vital signs and stuff. Be careful with the automatic cuff. Okay? And somebody that's really having low blood pressure, you probably can't track it very well. You might want to take a palpable pulse on the radial and use that as a systolic pressure instead of trying to use a stethoscope. Most of you, it's so noisy when these things happen that you can't really hear well. So a systolic radial pulse may be a better choice for you. This is the actual general treatment. Everybody gets these things. Oxygen, it looks good on TV. You see the aspirin. The load is fine, but long term you only give a low dose. Nitro spray probably is better than a pill because it doesn't require dissolving. And the morphine to relieve pain is great, but be real careful. When you give nitro, it decreases the venous return to the heart, so the heart's smaller. It's more efficient. It breaks out of the car and it runs faster. That's how it works. You say, well, it dilates the coronaries. Yeah, but the major effect is actually making the heart smaller. And by the law of Laplace, you took the stress off of it because you made it smaller. If you look at morphine, it does the same thing as far as venous return. It keeps the blood in the feet, just like this one does. If you add these two together and a guy has low blood pressure, you may put him in shocking position. So be careful when you add these two together. Now, let's say you do that and he gets really low blood pressure, like 60, and he doesn't look at it, he's pale. You know, his heart rate jumps up because you really have reduced the blood to his heart. You need to lay him down, lift his feet up. When you lift his feet up, you'll get around 70 cc's of blood back into his heart, and then he will work back up again. So if you screw up, that's the way to. There is an antidote for morphine called naloxone that you guys have available. If a guy stops breathing, that you can give it, but it still decreases the venous return, even the naloxone. There's a medication. We'll look at each one and how they're used. Certainly, you need oxygen to the ischemic tissue, and that's what you're going to try to do by, again, putting it on. This is only the VA patients have this COPD problem. I honestly don't think this is much of a problem anymore. Most of these guys are dead. We used to see this a lot. I mean, people would be sitting in here and say, oh, I saw a case last week. I gave him oxygen, he'd stop breathing. We don't see that because most of these guys have not made it. And we passed the World War II guys. Now we're into the Vietnam guys. They didn't smoke as much. So I don't think most of you will see this. Some of the senior people here may have seen some of those numbers really at its height, but those are pretty much gone. This is a nasal cania. You put it on your nose. How many of you breathe through your nose? Not many of you. Most of you breathe through your mouth. So it probably doesn't. But it looks good. In the family, expect you to put it on. Nitro, how's it work? It decreases the pain of ischemia if you can get blood into the ischemic area. Major thing is it decreases venous dilatation. It really vasodilates your veins, and so all the blood fits down in your feet. So it doesn't go back to your heart. So your heart's smaller, less stress on your heart, less myocardial oxygen consumption. It does decrease the venous return to the heart. I talked about here. It hits preload and some afterload, but it's primarily a preload reducing drug, and this is the major mechanism here. Notice in the sequence of events, they put this one after the preload. That's because this has been talked about a lot, but it probably is not the main effect. The main effect is decreasing preloading. Everybody talks about this. Yes, it does that, and you'll increase the capillary flow. Now, one thing nitro does, this collateral flow is important to you. If you close an artery and you're older, you will probably have made small microcapillaries that feed that same zone. Is it possible I can improve the flow to that area? It is. The only drug that will do that is nitroglycerin. Not a calcium channel blocker, not a beta blocker, not nitroglyceride. Only nitro. It has a special effect. So it has an ability to improve this flow. That's why we like nitro. So give nitro, and again, just watch the pressures, and it should do fine. It's a class 1 indication. Everybody should get it for the first day or two. Looks good. Especially helpful in pulmonary edema. If you have high blood pressure, especially in an anterior infarction. We've got mortality data for that. Persistent ischemia. And then these down here are very helpful. Watch this, it's on the test. Don't give it if the pressure is lower than 90. Because otherwise you'll really be struggling sometimes. This is how it's delivered. It depends on what hospital you're at, where you are, what you get. We like the spray. We found that most of the guys threw the spray away. So it was just too expensive to keep supplying. But if in your units, you may have just the spray. It's a lot more accurate than that. Here again is the blood pressure. Now, on the test, there is usually a real complex patient they'll give you. They'll give you a guy that's got a right ventricular infarction. And if you don't do heart disease every day, you may not be aware of it, but the way you generate blood pressure is from your left ventricle. It has to have blood in it, obviously, and it squeezes and generates the blood pressure. But if I don't put any blood in the left ventricle, because you didn't pump any over there from my pre-pump, which would be the right ventricle, you won't have anything to pump out. So if I was to infarct the chamber in front of the left ventricle, the right ventricle, then consequently, you will be hypotensive and you'll have trouble. If you give nitro to a guy with an RV infarct, you can actually drop the pressure even more and it'll be terrible. So how do you diagnose that guy? First of all, if you take the history, you will find that if you listen to their lungs on physical, and you take the history, the shortness of breath is not so prominent, and they'll have clear lungs. A guy with a left ventricular infarction has wet lungs, not dry. The other thing on the right ventricular infarction, if you look at the neck veins, they're going to be up because they can't get the blood through the right ventricle. It's infarcted, it's not pumping. So you'll see a big neck vein elevation. Those are probably the best tip-offs to tell you you got an RV infarct. And if that's the case, the treatment is totally different than left ventricular infarction. If you have a right ventricular infarction, what you need to do is give them fluid. And you may have to give 2,000 cc's. If you make a mistake and it's a left ventricular infarction, if the guy's already pulling their unit, you will probably knock him over. So on the right ventricular infarction, though, if you don't give it, then he won't make it either, because he basically would be dead at autopsy lab. And you say, well, why did he die? His left ventricle's normal. He infarcted his right ventricle. You didn't give him any blood back. He basically is in shock for a lack of blood. So you need to be pretty accurate on this diagnosis. So listen to the lungs. If they're clear and they seem fine and you have big neck vein elevations, you might want to do a test run of maybe 250 of saline and just see if the guy's pressure comes up or 500. And if they look like their heart rate starts to slow down a little bit, the guy's pressure comes up, you probably are on target for what you need to do. People with high blood pressure don't drop their blood pressure a whole lot at one time. For example, here's a hypertensive patient. Let's say his blood pressure is 250. Well, I'm going to take him to 140? No. You want to just drop him to about a maximum of 30%. And the reason is the brain auto-regulates. It takes time for the circuits in the brain to readjust to the blood pressure fall. That's what's perfusing the brain. You'll stroke the patient. We have seen that. So be careful. Don't rocket these people's pressure down. Just take your time and come down a little bit at a time. Don't just really drop the pressure. Headaches and tachycardia, the nurses will tell me about that. And then again, I would not have a patient that's getting these drugs be up walking around, or they should be in bed, so that you have good control of it. Morphine basically is the same type of physiology as nitro, only morphine does not put blood in the skin of its own or improve collateral. But it does decrease the venous return, and it makes a person so they don't care. If you make a person comfortable, take the adrenaline drive out of the system, you won't have as many VTAC or refibrillations. The thing that fibrillates a patient is adrenaline very quickly shortens the repolarization times in the heart and can really take off and go into VTAC. So this is an important drug, and I think it's probably stood the test of time. Again, watch the blood pressure, watch this volume status so you don't, if a person's dry or has an RV infarct, this is another one to watch for. This can get you in trouble. This is how it's prescribed. Use escalating doses of morphine to control the pain. It does drop systemic vascular resistance. And again, there's a warning about RV infarctions. Be careful, because if you're low on your venous return and you're already drying the heart and you take more blood out, this guy is not going to survive. Be careful with this group. Aspirin, I think I've already discussed a lot of this, so this should be kind of just review for you. Here's your thromboxane A2 that vasoconstricts, causes platelets to aggregate. And in doing so, that will close my artery, it will clog them up, and knock off the microcirculation, which feeds the cardiocytes that gives the troponin. And down here, again, we have data to support. We have mortality, benefit, we have reinfarction, and we have stroke. So aspirin is critical. Can you, if a person's allergic to aspirin, is there things that they can be doing that the brain salicylates into the body? There are. If it's a vegetarian and they eat lots of fruit, 4 or 5 portions a day, they will be taking in about 81 milligrams of salicylate. So if they can't take an aspirin, they can take in a fair amount of fruit and do a pretty good job. Here's the actual doses up here, how it's done. And again, the first starting dose is fine. And then watch for these down here. These are relative. Somebody that's got certainly a bad liver, I have one up on the floor right now. These guys cannot take some of these drugs, and they are a problem for us. But again, it's all kind of relative to where you are. This is the definition of acute coronary syndrome. Remember, I gave the unstable angina guys. This is your group over here. That's a low-risk patient. I gave these folks non-stemming. You're over there, and I gave you guys the ST elevation. Now, the left bundle branch block comes from the Augusto trial. Years ago, if you say, well, I can't read the EKG, but he's got a left bundle, do we not treat him? We do treat him. because we found that if they have classic symptoms and they have a left bundle, they're high risk. People with left bundles are higher risk for ischemic heart disease, and we save lives. So if you have a left bundle, classic symptoms, and if you're really good with the stethoscope and you have a third heart sound, which is coming from an ischemic ventricle because it has diastolic problems, then I would treat that guy. And you can give it lytics if you can't get an interventional cardiologist within the 90-minute time, or if you want to take him to the cath lab, you can do that too. But I would treat these guys. New left bundle, that makes us nervous. Here's how you calculate ST segment. Draw a line from the PR segment across, and this now determines the ST segment up or down level. That's where we get that from. Because the minute you say, well, you know, this is down, or I can't tell exactly where it starts, just draw it from the PR segment across. Now you can measure 1 millimeter up or 1 millimeter down. And that's how we determine the ST segment changes. This is an example from a computer-generated model. I think most of you can see this ST segment is pretty high. Doesn't look like the one I showed you before. You can't even hardly tell the T-wave. It's all kind of pushed together. That's definite. Shouldn't miss that. Over here's another example. If during chest pain you have this, the pain goes away, they come down. If you say, well, I have a patient's having an MI, I gave him lytics or he had an intervention. And if you look, STs are here, it's come down to here. This has to reduce more than 50% to be significant. If you still have 50% residual, the guy's probably still having pain. He's still infarct. It won't stay that way. It will eventually kill that piece of tissue. But, I mean, you didn't really take care of the problem. So you may have a residual area that needs to be addressed. But that's, again, showing you how it shifts out. Many of you want to know how to date a heart attack or how to date when this thing really started. First of all, it's kind of tricky and it's kind of hard to do. This is normal. Notice the T-wave. If you come up to the cath lab when we're doing an intervention, I'll blow a balloon up within about 10 to 15 seconds. The first thing that happens, the T-wave goes straight up. It almost matches the height of the R wave. So this is the most acute change. The next thing, it doesn't come down. You watch this, ST segment starts going up. That can be 2 minutes or a minute. And then if you wait long enough and this thing didn't go well, then you'll see this inversion. And then if you take a look up here, you don't see any negative deflection after the P wave. It goes straight up. Watch this one. Now you go Q. Killed tissue. And down here, it's even more impressive that they were so low. So that's how you can sort of date an infarct. But it's not perfect, but it's pretty good. This is a color scheme that's in your book. It shows you where the heart attacks go. If you look at the first two, you'll see that both of the hearts are aiming straight at you. You see the arteries coming off in this position. The other one is in the back. That's looking at the inferior wall of the heart. So what they have done is, if you look at the green zone, which is 2, 3, and AVF, you have to memorize this. If you're good at Enthoven's triangle, that's great. But most people just have to memorize the inferior wall is leads 2, 3, and foot. The 2 and 3 set on your shoulders. And you've got to have 2 out of the 3 of these to be positive. This is pretty good. It's only $6 to do the test, and I'll have to say, for a cheap test, it's not bad. So this will tell me what's going on. If you see changes in these leads, then you know you've got trouble. If you have changes in the precordial leads, the one they stick on your chest all the way across, if it's up front, that's anterior. If it's down around the armpit, that's lateral. That's probably all you need to know. So V1, V2, 3, in that area, it's an anterior mile. I really don't care if you tell me it's septal or not, it's all relative. In general, I don't do hematology, I don't do many of the things you guys do, but I can, in general, just remember, if it's up here, it's anterior, that's a pretty important area. The lateral wall is also probably the circumflex territory, and then 2 to 3 and after the feet. And they'll ask, in general, those questions on the test, but not too specific. If you look at this one, here's the leads V1 through 6. I think most of you can see the STs are up. Look at there, and that is the EKG that I showed you earlier. And a very young patient, and you can see the whole front wall is going down. That's anterior, that's right up front. STs are up here, 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 across. That's an anterior line. So that kind of gives you an idea how you read them. Beta blockers, what do? Basically, they're anti-adrenaline. When you guys get excited and nervous, your adrenaline goes up, and your beta stimulating your heart rate, blood pressure, and things like that. This is a drug that actually will cool off the catecholamines or adrenaline, so it's not so rhythmogenic. This is a great antiarrhythmic drug. We use it for most all the infarcts. Anybody that's tachycardic, they're going to get beta blockers by and large. It shuts down the heart rate, which is very important, shutting down the actual oxygen in the heart, blood pressure, and contractility. At the same time, it can slow conduction through the AV node. So if you get a heart block, don't use this. This is not a good choice. And if you want to look at decreasing VFib, or somebody that's fibrin, decrease the chance of you having to resuscitate them, give them a beta blocker, because it will decrease that risk. How do we know that? We've done that in animal testing, where we've actually fibrillated hearts in animals, and if you give them a beta blocker, it's harder to get them to start. So it does work, and it works in humans too. So keep that in mind. Many of you are familiar with a drug called amiodarone. When you first give it IV, it's a beta blocker. That's how it works. Its other effects don't occur for a day or so. That's how that drug actually works. So when you give it, you watch the heart rate slows. It's because it's a beta blocker. And at the same time, it also dilates the arteries. At the same time, it also blocks platelets. A very interesting compound. But it also has a ton of side effects. So we don't use it easily. We watch carefully. Here's your contraindications over here. And over there's precautions. The diabetes is precaution. It's not critical. But again, watch these carefully. You will see some of us use this in some of these areas, but this one right here, we all stay away from. Nobody wants an asthma attack during chemo. I have no treatment for that. The treatment for asthma attack, by and large, would be steroids, which thin the ventricle when you infarct. And the other one would be, is that if you give them isoprel, it speeds the heart rate up and fibrillates the patient. And you don't want that either. So they have asthma, they don't get a beta blocker, they get a calcium blocker. Okay, just so you know, because you'll get asthmatics in here, and you'll get people that have different kinds of problems. But watch for this one. This will hurt you. If somebody you don't want to treat that. This is heparin. It's not going to go away because it's really cheap and it works really quite well. One is the mechanism of action. It requires actually any trauma tree to be present for it to block trauma. It's excellent because I can turn it off and I have an antidote. So if you have to go to surgery, you turn it off and you're ready. If you stick an artery and it starts bleeding, you can basically turn it off, pull it out, and you're doing fine. If we do fibrinol-specific lytics, you need to give heparin because there is an activation sequence of the platelets in some of the other clotting factors when you actually are changing these lytic drugs around. You need heparin to block that effect, and that's very helpful. And then for the high-risk people, if you see a big old clot in the left ventricle because they're infarcting and it doesn't pump the blood around very good, it helps decrease that risk. And so we do use it for that too. This is the ACE inhibitor. Now, I don't recommend you use ACE inhibitors in the first day because if the patient's rocky blood pressure-wise, you want to make sure that the guy's stable. So what you might want to do is wait for one day. If the blood pressure's fine, then start the ACE inhibitor. What does it do? One is it decreases death long-term. It takes the pressure off of the heart. It also affects the remodeling process of the heart. So where you infarct, that tissue probably is not going to do well. But next to it is areas that are not quite sure whether they're going to infarct or not, or they're not going to live or die. This drug can change the signals that tell the other parts of the heart to live or die, and it's beneficial. So we do use ACE inhibitors. Be real careful because it's, again, it vasodilates the patient, decreases venous return. But it definitely helps remodeling. It does reduce mortality. We have a number of trials that show that, and it's one that will probably continue to be used. It's an important one. Here's the fibrinolytic drugs. They break up the fibrin networks. Now, aspirin, it's platelets. This is related to fibrin. The first thing that comes when you cut your hand, you cut it, it's platelets. They'll come there first. The next thing that comes is you'll see fibrinogen and all these other products come over to clog up the whole really permanently. So if you have already closed your artery, you need to open it. The newer drugs will actually come down here and actually open this up. Tenecteplase is a drug that I think most of us have here. The reason we pick this drug is one shot, and it will actually go after clot-bound trauma and dissolve it. But at the same time, if you had a recent head injury or something like that, it will dissolve that too. So be careful. If somebody had a recent bleed, these definitely will open up things sometimes you don't want. Here's the 12-hour period. If somebody's over 12 hours from a heart attack, probably this is not going to change much, and the risk-benefit ratio says you probably shouldn't do it. But if they're severing, you're not going to consider it. But these drugs do work. Do they work better than an interventional procedure? If I was in the hospital and I could get on the cath table and got open artery, that's probably the best. If there's going to be a delay, give the lytics, and then I'll suffer when I get to the cath lab with the fact that they're on it. So don't worry about us sticking the leg, even if you get the lytic, I'll go stick it anyway. We have new techniques that we can get in and do things with. But this this is very worthwhile to know because the fibrinolytics do things that a stent cannot do. The microcirculation is plugged up with microparticles or platelet particles. And it also has a lot of fibrin down there. These drugs will go into the microcirculation in open areas that a stent won't. So there is some discussion of whether or not in acute infarct you should give these drugs first. If the patient opens very quickly, then they don't get an intervention until the next day because the body has its own compounds it releases that helps clean up the area so you don't have as much trash that goes downstream. Your endothelial cells secrete a compound called TPA. That tissue plasmid activator is really important to you, and it will help clean up the system. So we're giving these drugs to open it up, and then your body hopefully will come through and actually put out some more. Here's these different types of blocking agents. I showed you the fibrinogen links between the platelets. The thing that breaks that is you're going to break that bond in that receptor. You're going to shut down that receptor up there. There's two ways you can do it. You can give something like Plavix that goes to the ADP, and then it comes down and shuts off the glycoprotein 280 receptor so they can't connect the fibrinogen to form a clot. Or you could just give a real powerful agent up front, like integralin, and it will totally just cut the legs right off of the TB3A. But boy, once you give it, let me tell you, it really works. It will flat knock it off. So be kind of careful when you want to pick one of these. Will you be starting this, or will be the cardiology guy starting this? You know, quite honestly, most of you will start this. This will be started at the emergency room. And so you'll need to know a little bit about integralin. I don't think you have to know these other two so much because you don't use the integralin has been around and worked pretty good. The one thing about integralin, when you start talking about using antiplatelet agents, notice it says not for ST elevation MI. We did those studies, and that drug does not have help in ST elevation MI. It's only for people that have non-STEMIs. That's what it's indicated for. You must have positive troponins, and you must have non-STEMI. If you have ST elevation MI, they are not to be used. These drugs don't use these in people that have an ST elevation MI. They don't work. Vein grafts don't know. So try to pick carefully your choices because you may give a drug that is not helpful, but you increase bleeding risk. So that's not good either. And I'm going to skip that for now. Okay, let's let your brain rest for a minute. Lead 1, 2, 3, R, L, and F, and then beat 1 through 6. These are up. This is lead 2 and 3, and that's the one you had to memorize. That's your foot, inferior wall. Most of the time, it's the right coronary artery. It could be the SIR, but most of the time it's probably the right. So if you're reading this EKG, this is acute ST elevation MI. Now, if it just happened, your troponins would probably be negative because it takes a couple of hours to go up. But most people, especially the guys, you know, they will probably be up when we get to the hospital. And usually if it's their spouse, they don't take them. It's very interesting. Women come to the heart attacks at least probably an hour later than the guys because I guess they don't. Guys don't take them. I don't know about that. But you'll find that most of the women come in, but the women when they come in with a heart attack are usually 10 years older and have more risk factors. So it's not quite the same, but these ST elevations are clearly inferior wall when you look at it. Here's another example. This is 1, this is L, and you see it over there. That's probably lateral wall. You don't have to, no, that's not an test. That's too specific. But again, the ST segment should catch your eye. These should catch your eye. That's the anterior wall. Now the veteran probably has already had one in mind. He may be coming back for his 3rd or 4th. So you may find that he didn't have much force fields at all. Or, you know, well, I've already had one heart attack. You know, and that's coming from another area. So kind of be, that means your blood pressure is at risk, cardiogenic shock's higher, and they're much more risky patients. But that's an example. Here's another one showing you the same thing. And if you see these ST segments, certainly they're up over here, ST segments are quite depressed. Now, what could be the case for the ST segment depression and the elevations in other leads? It is possible, most likely around here. You already are closing one artery, but you got 95% blocks in the other 2 arteries. Now the heart can't handle it because it can't take a heart attack and have 95% blocks in the other arteries. So basically, the whole heart's going down. So you're getting ischemia at a distance. You're infarcting this one vessel, but the other ones are in trouble. I have a lot of 3-vessel disease upstairs. So you need to kind of keep in the back of your mind, they're not infarcting one vessel. They may take that one out, but at the same time, they probably have other vessels that are also got high-grade blocks. 60% of the time, a guy that infarcts one artery has a 70% block in another one. That's how they got to it. So it's all kind of, you know, watch your patients, but here at the VA, I assume they probably got more disease. Here's an example. She's not exactly over the hill in age. I think you can see, this is her LED, totally missed it, I put a stent in it. And she's had a heart transplant now. That's her EKG. Look at this, the whole front wall's coming out. Now, she took a little time to get to the hospital. If you look, she's got Q, Q, Q. She's already lost most of the front of her heart. And she ended up with a huge baggy heart. She did not do well. So again, it tells you that this is the pattern on EKG, and here's your artery clogged up. Shut off completely. I can open it, but the damage is so extensive that I can't, it just won't repair. In the first 20 minutes, 50% of your heart size is determined. If you wait an hour or two to come in, I say 5%, 95% is gone. So you got to get there pretty quick to save that heart. Here's another one, inferior wall. And if you look, you've got some ischemia over here. Now, some of you may see the voltage is real high, so you have also probably high blood pressure on top of the fact they're having an inferior wall MI. That's probably the right coronary artery. The previous one was a left anterior descending, a little bit different than this. They both can be bad, and either one can kill you. The thing that really knocks you over is not sometimes the specific artery, it's whether you defibrillate before you get to the hospital. And most young guys that don't have backup collaterals won't make it to the hospital. The old guy that's had a heart attack before, maybe 2 or 3 times, he'll probably get there. You know, because he's got some backup support. But many guys don't have it. Here's an ugly looking one. Look at this one. Huge, 2, 3, and F. And on top of it, here's lead B1 through 6. You see this marked depression here. That's because underneath the bottom of the heart, the right coronary is probably dominant, and you're taking out even more of the bottom than you thought you were. So that's, again, I hope you wouldn't miss this. Even if you forget these leads, you just have to call the cardiologist, hey, listen, ST segments are up. That's good enough. We'll come and look. You know, I don't do your stuff and you don't do mine, so you know, it's a team effort. So just call us and we'll be more than happy to come and help you. This is down. You can see it here, and again, look over there, and you can see some ST segment changes. If you have positive troponins, that's a non-STEMI. And that guy could get integrum, and he could get evaluated quickly. If you can stop his chest pain, you leave him on aspirin, the heparin drip, or if you want to add a 2B3 if it's indicated, this guy would probably cool off and I'll cap him the next day. But if he doesn't, he'll be capped today. Here's one. Here's a left anterior descending artery, and look how it's torn the artery backwards. You can see the lip underneath it. That's a ruptured plaque. That's what most of you do. Before you, if just a few minutes before, it may look like this, but once you crack that from high blood pressure or you get a captive stent and breaks, you got a problem. And then here you will see EKG changes like that. During the time this breaks, it will activate clotting. And when it does, the platelets come rushing down there. And if it clots off a lot, you will see the EKG change the T waves, and these things will flip up and down. When you've got to get chest pain, they'll be down. When he has no chest pain, they'll be up. It can be that, it can change within just a minute or two. So in the lab, we can see that, and what's happening is this is throwing trash or different types of material from the blood system downstream into the microcapillaries, and you're reading it with the EKG. So you can see that in the lab as it's going on. Here's another example of T-wave conversions over here. These are pretty impressive. If the guy has, again, chest pain, positive troponins, then that would be one. If he had no chest pain, no positive troponins, I don't like the T-waves, but he would classify into a guy with unstable angina. Although that's pretty impressive EKG changes, so he probably has some actual pain with it. Could you diagnose a guy that's having a heart attack with just a stethoscope? Well, you could certainly tell that the ventricle is stiff because you hear a third heart sound. You would see an increase in his heart rate, and you would see an increase in his blood pressure. So the physical findings of ischemia, elevated heart rate, elevated blood pressure, and a third heart sound. So you can pick that up, but you'd have to listen pretty carefully. With the bellow of the stethoscope, with the patient kind of rolled over to the left side a little bit, listening to the apex of the heart. And in most of the hospitals, they have so much ventilation you can't hear. So I think the blood pressure elevation and history and heart rate probably would be the tip-off. Here's another example of an EKG. If you look over there, you can see the T-wave conversions. Clearly, the voltage is quite prominent on this case. Again, depending on whether or not the troponins are positive or negative in history, he would fall into certainly not, he's not having an acute MI, ST elevation, but it would need to be acute pulmonary syndrome, one of the two. Now this is a veteran probably. So if you take a look, Q, 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 all the way out. So he basically infarcted most of the front wall of his heart, maybe the lateral wall. But that's not all he was doing. Now he comes in with chest pain, and he's infarcting a different part. So now here's an example of a guy that probably got severe through vessel disease, or maybe even a bypass, that's taking out another part of his heart. So you, again, just look at the tracing, look at the patient. These are usually older men, and they've already had a number of heart attacks. Here's EKG. The point of this slide is to say, many of you ask, well, his R waves are not progressing. He still doesn't have very much R wave here. If he transitions by V4 to where he has more R wave than this, that's okay, and that's considered appropriate. That would be an example of probably normal tracing. This is the last slide. So, which animal lives the longest? And since we're all animals, you want to know how we figure this out. Here's how it goes. If you take a look at your endothelial cells that line your body, just like your hand has a skin lining all over you, you have 6 trillion cells. The guy in the animals that live the longest is the ones with the lowest insulin levels. That means that the metabolic circuitry at the cell level is superb. It handles it very well. These animals are by and large calorie restricted. If you want to look at the oldest patients that we see in the lab, by and large, most of them are little old ladies that are skinny. They're not guys. You don't see many guys on the camp table that are real heavy after 70. They mostly have heart attacks or die. Only skinny people after that. Down here is genetics. You've got to pick the parents well. Same way if you have animals, I have dogs, and I always look at the animal life of the mom and dad of the dog and what their life was. That will give me a good idea of what to expect. The rest is up to you. It's your choices. You can take drugs if you want to lower your cholesterol or lower your blood pressure, which are great. They will increase your life expectancy about probably 3 or 4%. That means that if you took a statin drug, and I have a car tire that will go 100 miles, and I give a statin drug to my other car tire, it will go at the very best 104 miles. That's it. That's all you're going to get. If I give you a blood pressure drug, it's about the same. But if you use an exercise, I can get you to 140 miles. Of course, that's not popular. But that's the best way to keep out of acute pulmonary syndrome. Okay, any questions you have? Enough material? It's a lot of material. It's all in your book. Look at it and see. It's supposed to be a storyline so you can kind of track it easier. But this is a huge section. But at the same time, it's the most common one you see in the street. Okay? Thank you all very much.